Is it visible?
Yes, sir.
Okay. So already, I think case scenarios have been sent to you. So this was the first case scenario that has been sent. Who is going to answer all that? Balaji Medical College students?
Good evening, sir. This is Dr. Shashank, sir. Can you hear me,
Shashank,
sir?
yeah, good.
Yes, sir.
So the
So,
first
sir,
case scenario that is given to you is this. Nowadays you get about 25 ASCII questions.
yes, sir.
You have to answer. Each question has only about 4 to 6 minutes time for you to answer. Okay.
Okay,
So it has got some subdivisions like these questions, 3 or 4 or even 5 questions. Subdivisions may be there, and they give marks for each subdivision, like 2 marks,
yes, sir.
3 marks, depending upon the answers. So, what is your answer for these questions here? What is the probable diagnosis in this case?
So the probable diagnosis here, since the patient already is hypertensive, is probably pregnancy-induced hypertension presenting with preeclampsia, sir.
Straight away, you can say preeclampsia here.
There's no proteinuria, hasn't been mentioned anything about proteinuria.
So for this, what I would like to do is, that is why they are given its probable diagnosis. Okay. So
Yes,
when they give a clue like this as probable diagnosis, you can say gestational hypertension if there is no proteinuria, preeclampsia if proteinuria is plus. Okay.
yes, sir. Yes, sir.
So better just you give both the options. Then don't jump straight away, because the next question says preeclampsia. It doesn't mean that it should be a preeclampsia case. So
Yes, sir.
always go with the question and then try to answer that. Right.
Okay.
What are all the enumerate the 4 warning signs of preeclampsia with severe features, or it is otherwise severe preeclampsia?
So patient may present with blurred vision, headaches, hematuria, reduced urine output, and abdominal pain more focused on the right upper quadrant, sir.
Okay. Will you call them as signs?
More like symptoms.
They are all symptoms. So
Symptoms.
the question here says enumerate 4 warning signs of preeclampsia with severe features. So you should remember the difference between signs and symptoms. So if you write all the 4 what you have enumerated, they are all symptoms. Patient will only complain of headache. You cannot elicit to have a headache in a patient, isn't it?
Yes, sir.
Whereas edema you can elicit in a patient. Even if he complains of swelling in the leg, you can see the edema. It is a sign, isn't it?
Yes, sir.
Similarly, if he says upper abdomen, right quadrant pain, it is patient who is complaining. But if you feel a palpable liver, that is a sign.
Sign. Yes, sir.
Hepatomegaly is a sign, but hepatic pain or upper abdominal pain is a symptom. So
Yes,
what
sir.
are all the 4 signs you have to describe here?
So bilateral pitting edema, hepatomegaly.
Severe features. Bilateral pitting edema may be there for a long time,
Common.
but what is going to be very described as severe one? So confusion, patient is confused, okay?
Yes, sir. Yes, sir.
Because of the hypertension, patient may be confused. They may not be passing enough urine. Due to the catheter, a very little amount of pain is there, and when you touch the epigastric region, patient may be complaining of pain, and there may be features of pulmonary edema, overload. Okay, so this is how you have to write for signs. So look at the question properly. If they ask what are all the symptoms of preeclampsia of a severe nature, then you can say headache, visual disturbance, all those can be described. But if they say 4 warning signs of preeclampsia, go with the ones which were very, and what are the name 2 drugs for management of hypertension?
You can use IV labetal also, hydralazine, nifedipine.
No, only 2 drugs. Answer only for the question. So labetalol and
hydralazine.
like that. Yeah.
Yes.
What are the 3 components of HELLP syndrome?
Hemolysis, elevated liver enzymes, and low platelets, sir.
Excellent. So these are the 4 answers. If you write like this, you will get full marks. ASCII is one situation where you can get maximum score. And probably that is the reason why nowadays we are getting 100% results, because students are doing very well in Osce and getting the maximum marks. Okay. So coming to the next scenario, ask the question. And so 26-year-old male weighing 50 kg has been given rocuronium bromide 45 milligram. Is that the correct dose for a 50 kg person? What is the dose of rocuronium?
Around 1.2 mg per kg, sir.
0.8 to 1.2. Okay. So
Yes, sir.
this is probably the correct dose for intubation, and he could not be manually ventilated or intubated. So what is the drug of choice for immediate reversal of neuromuscular blockade in this
Sugammadex,
patient?
sir. Sugammadex, sir.
Sugammadex, very good.
Yes, sir.
What is the dose of?
Dose I'll administer to this patient would be dose of 16 mg per kg body weight. It comes down to 800 milligrams, sir.
Excellent, excellent. There are 4 doses available for
Yes,
very late reversal after giving the drug and waiting for a sufficient time, 2 milligram per kg body weight. Intermediate block, 4 milligram per kg body weight. Immediate reversal after giving the drug for intubation, 16 milligram per kg body weight. Okay, so that is what you have to remember. What is the mechanism of action of this drug?
So sugammadex enters the tissue and creates a concentration gradient, and then it binds to rocuronium to form a complex. And this complex allows the neuromuscular blocker to move from plasma, thus creating a reversal of the neuromuscular blockade, sir.
One word on specific terminology has to be used. What is the terminology you will use with regard to its mode of action? It encapsulates the rocuronium. Okay.
Okay, sir.
It is like a donut. It will suck in the drug inside and then cover it. It has got a hydrophilic and a hydrophobic center. So it will attract the drug and keep it inside. And that's called encapsulation. So that is the mechanism by which it removes and destroys the drug. So that terminology has to be used. Mention 2 common side effects of this drug.
Nausea, vomiting, headache.
Flushing, vomiting, all these things, right?
Yes, sir.
So another question is, a 68-year-old man with history of MI 4 weeks back was admitted with gradually worsening breathlessness. On examination, he has severe respiratory distress and is using axillary muscles of respiration. The JVP is increased and he has bilateral pedal edema. There are bilateral crepitations in the base of the lung. On auscultation, his vitals are pulse rate 128 and respiratory rate 40, BP 144/70. SpO2 93% on 15 liters of oxygen. So the ABG values are hydrogen 63, pH 7.15, PCO2 52, PO2 80, bicarbonate 14.2, base excess is 9, SpO2 93, SaO2 93, lactate 4.9, sodium 141, potassium 2.7, chloride 100. So, what is the type of respiratory failure in this patient? That is the first question.
Type 2 respiratory failure, sir.
Very good. Why do you say it is type 2?
So type 2 because once the PCO2 levels are raised, so for this patient, hydrogen ions are
Type 1 is
raised.
near hypoxia. It's a
Hypoxia.
normal PCO2. Whereas
Yes,
type 2 is both hypoxia and hypercarbia. Okay?
Yes, sir.
So this patient is hypoxic as well as hypercarbic. So it is a type 2 respiratory failure. Okay. Mention the key difference. That is the second question that we have already answered.
Yes, sir.
Key difference between type 1 and type 2. It's a very straightforward and easy question. Describe the acid-base status.
Metabolic acidosis with compensatory respiratory alkalosis, sir.
Metabolic
Acidosis, sir.
acidosis with compensatory
Respiratory alkalosis.
respiratory alkalosis with 52. Is it alkalosis?
Raised.
If it is gone down to 28 or 30, then you can say call it as a compensatory respiratory alkalosis. But here PCO2 is also high.
Yes, sir. Okay, so it's not
40 plus or
compensated.
minus 5 is the normal value for PCO2. So how will you differentiate whether it is respiratory acidosis or metabolic acidosis? Because in respiratory acidosis with the PCO2 rise also pH can go down. So pH
Yes, sir.
7.15 is primarily an acidosis, isn't
Acidosis.
it?
Yes, sir. Yes, sir.
So PCO2 rise also can go to produce a respiratory acidosis. So how would you differentiate whether it is respiratory acidosis or metabolic acidosis which is causing the lowering of the pH?
Sodium bicarbonate and lactate levels.
Sodium bicarbonate
It's reduced in this
is
patient. So
low.
it's metabolic.
So
Yes,
it
sir.
is must be a mixed disorder. It
Yes,
should
yes,
be a
sir.
mixed disorder of both respiratory acidosis and metabolic acidosis. Okay.
Okay, sir.
So a patient he may be a COPD patient or he may be a patient already having a MI and all those things. So if he has been having a respiratory acidosis, there should be a compensatory increase in bicarb. And when the bicarb level is going down, that means he is developing a metabolic acidosis on top of that respiratory acidosis. And what is the other very concerning thing here? To make sure that the metabolic acidosis is also very bad in nature, or
Hydrogen
how
ions
could
being
the
raised, sir.
metabolic acidosis could have been caused here? What is this
Lactate,
value
sir.
you are seeing?
Saturation, sir.
Lactate, is it
Lactate.
normal?
No, it's raised, sir. It's raised.
So hypoxia producing anaerobic metabolism, producing lactate, it may be the cause for the metabolic acidosis. Okay,
Yes,
so
sir.
probably he is having respiratory acidosis already. On top of that, because of the hypoxia, he has gone in for anaerobic metabolism, which has also compounded the issue by producing a metabolic acidosis also. Okay, so if they describe the acid status, you have to say this is a mixed disorder with both metabolic and respiratory acidosis. So what is the likely diagnosis? That is what. So these are all the things that you have to describe. And what is the cause of metabolic acid-base disturbance? And that also again I have described how hypoxia producing anaerobic metabolism and causing this disturbance.
Yes, sir.
Now this is another scenario. 5-year-old child being resuscitated in the ICU. What assisted ventilation rate should be maintained during the resuscitation effort?
So
Patient resuscitated means the patient is undergoing CPR,
CPR.
cardiopulmonary resuscitation.
Yes,
So
sir.
what should be the ratio between ventilation and compression?
15:2, sir. And if advanced airway has already been secured for this patient, then what is that, sir? Continuous compressions with breaths every 2 to 3 seconds, sir.
So single rescuer, double rescuer, airway, all these differences are there. Okay.
Yes, sir.
So if you are a single rescuer, then you go for 15:2. If you are there are two people, one to take care of the respiration and other to compression, then the rate is different. When you have a endotracheal tube in situ, then you go for 12 respirations per minute. I mean 6 respirations per minute every 10 seconds, and continue with the compression. So how do you estimate the weight of the child to calculate epinephrine dose?
So weight is equal to 2 times age in years plus 4.
Plus
4, sir.
weight
Plus
is
4.
equal to 2 times the
2
age.
times the
Only
age
2
plus
times
4.
the age. Veach's formula. There is a formula called Veach formula, isn't it? Have you heard of that?
No, sir.
Age divided multiplied by 2 plus 8. Okay. So for a 5-year-old child, 5 into 2 is 10. 10 plus 8 is 18. So its weight should be expected, or ideal weight will be 18 kg for the 5-year-old child.
Okay.
Right? And
Yes,
for
sir.
defibrillation shows VF. How do you decide the shock energy for defibrillation?
So for the first shock, we'll give 2 joules per kg body weight. For the second shock, it's 4 joules per kg body weight. And for the third shock, it's more than 4 or an adult dose, like more than 10, sir.
Oh. What about the dose of epinephrine?
Epinephrine doses for IV or intraosseous dose is 0.01 mg per kg body weight, with a maximum dose of 1 mg, which can be repeated every 3 to 5 minutes, sir.
0.01 to 0.03, the first thing range. Okay?
Okay, sir.
If it is intratracheal, you can go 0.05 to 0.1, and maximum you can repeat as you said.
Yes, sir.
Identify this equipment.
So this is an Ambu bag, sir, or also called the
What is the other name for Ambu bag?
artificial manual breathing unit, sir.
That is the expansion for Ambu. What is the any other name for the Ambu bag?
Self-inflating bag.
Self-inflating. Very good. It's called the self-inflating resuscitator also. Okay.
Yes, sir.
So what are the name the parts A, B, C, D?
So A is the self-inflating bag, B is the reservoir bag, C is the input to connect to the oxygen outlet, sir, and D is for connection to the reservoir bag, sir.
Into the reservoir. C is the oxygen carrying tube. What are the 2 disadvantages of this device?
So when the patient is spontaneously breathing, won't be able to assess, and you won't be able to feel the lung compliance, sir, with the Ambu bag.
Much more important than that is, one is you can insufflate the stomach if you are not holding the mask properly and then doing it. Second thing is you can exceed the pressure and produce barotrauma. Okay, so those are the 2 more dangerous disadvantages. So stomach insufflation and especially if you are doing it in a hurried fashion in an emergency, can cause high airway pressures and then cause barotrauma also.
Yes,
that is why nowadays we have a pressure releasing valve which is there to release the excess pressure if you are doing it in a very hurried fashion. Okay. So these are only the 5 ASCIIs that has been given to you. But I will just add some more as newer advances and produce some ASCII questions. Let us see how you fare in that. So the first one is a 60-year-old man with a 5-year history of myasthenia gravis is scheduled for a transcervical thymectomy. He has generalized moderate muscle weakness and has recently been requiring higher pyridostigmine doses to control his symptoms. His preoperative investigations show a post-vital capacity of 3.5 liters. Which of the following is the most appropriate post-operative management for the patient? Is it reversal and extubation, discharge on the same day, or transfer to ICU for overnight ventilation, or reversal and extubation on table and observation in high dependency unit, or do elective plasma exchange to help early extubation? Which is your choice? Can you reverse the patient and extubate him and discharge the patient on the same day?
No, sir.
Only a transcervical endoscopic procedure.
So reversal and extubation on table and observation in high dependency unit.
Reversal, extubation on table and observation in high dependency unit. Very good. That's the correct answer.
Yes, sir.
Now, what are the factors which determine that? The explanation is the factors which determine elective ventilation in post-thymectomy include long-standing disease, more than 6 years. Here it is only 5-year history, and vital capacity less than 2.9 liters. If this is here it is 3.5, and history of chronic respiratory disease. There is no such thing in this patient. And type 3 or 4 myasthenia gravis. So Based on these findings only, you decide about. So as this patient has a vital capacity above the threshold as not having a transsternal procedure, it would be judicious to extubate him and then monitor him overnight on any respiratory complications if they develop. That is the first type. What are called hip fractures? What are all the fractures? You will call them or as hip fractures. Which area of the hip joint? Which structures in forming the hip joint you call them as hip fractures?
So around the head of the femur, neck of the femur, the acetabulum.
Yeah, the term hip fracture encompasses a range of pathology from the acetabulum to the proximal femur. Okay, so anywhere between acetabulum to proximal femur, they are all called hip fractures. What nerves innervate the capsule of the hip joint? Nowadays, in your exams, you are going to get a block pertaining to this. That is why I thought I will choose this topic.
The femoral nerves are branches of femoral nerve.
Femoral, lateral connecting operator, okay, accessory operator. They supply primarily the anterior capsule. Okay.
Yes, sir. Yes, sir.
The sciatic nerve, superior gluteal nerve, and nerve quadratus femoris supply the posterior capsule. So the capsule of the hip joint is divided into anterior and posterior capsules. Anterior capsule is mainly supplied by the femoral operator and accessory operator, whereas the posterior capsule is supplied by the sciatic nerve, superior gluteal nerve, and the nerve quadratus femoris. What is the difference between the anterior and posterior capsules of the hip joint? Why they have been divided into these two categories, anterior and posterior?
Yes, sir.
The anterior capsule has the densest occupation of nociceptors and is responsible for the pain caused whenever you have an injury. Okay.
Okay, sir. Yes,
so the anterior capsule is the pain capsule, whereas posterior hip capsule is predominantly mechanoreceptors and does not require routine analgesic treatment. That is the major difference between the two. So what is the sensory innervation for the skin over the hip joint? The capsule we saw, it is the branches from femoral operator, accessory operator. But for the skin over the hip joint, where they make the incision to approach the hip joint, what is the sensory innervation?
Lateral cutaneous nerve of thigh, sir.
Very good. As so the relevant skin lateral femoral cutaneous nerve, which is arising from L1 to L3, and lateral cutaneous branch of iliohypogastric, which is L1, and subcostal nerve T12 there. Okay.
Yes, yes, sir.
And what blocks are used as on-arrival blocks in hip fracture patients?
Femoral nerve
the
block,
patient comes
PENG
in.
block.
Huh?
Femoral nerve block, PENG block.
So femoral nerve block and
PENG, sir.
PENG block is only for mostly post-operative pain relief or as a supplement for intraoperative procedure. So infrainguinal fascia iliaca block. Okay, recent cautionary and systematic review meta-analysis shows infrainguinal fascia iliaca block or femoral blocks are the two blocks which are commonly used for hip fracture. What is PENG block? What is the expansion for PENG block?
Pericapsular nerve group.
Pericapsular, very good.
Nerve group block.
Nerve group block. Okay. So pericapsular nerve group block is PENG block. It's a regional anesthetic described only in 2018, just 4 years old. Developed primarily in hip arthroplasties for post-op analgesia with motor sparing effects. Okay. The PENG
Yes.
block is now asked in your theory examination also. So you have to read about that. I am showing the technique. What is this? What block is being performed here?
PENG block, sir.
This is the PENG block. Very good. It shows the UST guided PENG block. What are the, expand all the abbreviations that you see? FA, FE, FN, IPE.
Femoral
AA,
artery, femoral vein, femoral. So FA, femoral artery, femoral vein,
femoral artery, femoral vein, femoral nerve.
femoral nerve.
Color coding is also there to easy identification. What is IPE? And what is AIIS?
Anterior superior iliac spine, sir.
AIIS, not ASIS. Anterior superior iliac
Anterior
spine.
inferior, anterior inferior.
Anterior inferior iliac spine. Yes. So FA femoral artery, FA femoral vein, FN femoral nerve, IPE is iliopubic eminence, and AIS anterior inferior iliac spine. What are the advantages of PENG block? Already you got the answer in the previous slide.
We block more nerve roots, sir, compared to femoral.
It is a motor sparing block.
Sparing.
So ambulation is there without pain, provides more complete analgesia to the hip joint. Motor function of the involved extremity is spared, and PEN block can be used alone as a primary analgesic or in conjunction with other forms of anesthesia during surgery or in the perioperative period. What are the complications of PEN block?
Intravascular injection, local anesthetic, systemic toxicity.
General complications like any other block can have infection, bleeding, neuropathy, systemic toxicity. Any specific problems? Quadriceps muscle weakness may occur secondary to the femoral nerve blockade. So that is the only problem. So you have to use lesser concentration. Enumerate few causes of hypervolemic hyponatremia. Hyponatremia is a very common clinical picture that you will see, especially in the elderly after a few surgeries in the post-operative period.
Yes, sir.
Okay. The main causes of hypovolemic hyponatremia are congestive heart failure, liver cirrhosis, and renal diseases such as renal failure and nephrotic syndrome. Mention the aids to evaluate the euvolemic and hypovolemia in patients with hyponatremia. What are the tests by which you can measure the euvolemia or hypovolemia in patients with hyponatremia? Two tests that you can perform. Euvolemia means patient's volume status is normal. Hypovolemia means he is having a contracted volume. So what test or what estimations will tell you about the volume status?
Urine sodium.
Two useful aids for evaluating euvolemia or hypovolemia are measurement of plasma osmolality and urinary sodium concentration. Okay.
Yes.
So plasma osmolality normally is 285 to 290. Whenever patient becomes hypovolemic, what will happen? Water content is less, ion content becomes more. So he will mimic a picture of hyperosmolar state. Okay.
Yes.
And urinary sodium concentration will be altered. And that is the hyponatremia. What are vaptans? How do they act and what is the result of their action and indications for use?
Vasopressor receptor antagonist, sir.
Very good, excellent. How do they act?
By aquaresis.
So this is a newer class of drugs which are being used mainly orally and intravenously active non-peptide vasopressin receptor antagonists are called raptans. They are non-peptide drugs. They are not proteins.
Yes, sir.
And raptans block vasopressin type 2 receptors in the collecting principal duct cells and therefore induce aquaresis, mainly water elimination.
Yes, sir.
So the indications for their use are congestive heart failure, cirrhosis of liver, syndrome of inappropriate secretion of antidiuretic hormone, polycystic kidney with hyponatremia. So in all these patients where there is an excess water in the body, which is causing a dilutional hyponatremia, if you give this raptans, it will excrete the excess water and bring back the sodium to normalcy without the need for replacement of sodium by itself. Okay, that is the idea of usage of raptans. So they have to use them only in congestive heart failure, cirrhosis of liver, and SIAD patients. How
Yes,
to calculate the correction of hyponatremia in a 70 kg patient with a serum sodium of 110 milliequivalents per liter using 3% saline? I think this was asked in the last exam Osce also. How to calculate this? So formula for correction of hyponatremia with 3% saline is sodium content of the infusate, that is the IV fluid that you are giving. What is the sodium content? Subtract the measured serum sodium of the patient and divide the whole thing by total body water plus 1. So for example, the sodium content of 3% saline is 513 milliequivalents.
Yes, sir.
And the patient's value is only 110. So 513 minus 110. And total body water is 0.6% or 60% of anybody's body weight is the total body water. So for a 70 kg man, 0.6 of 70 is 42 liters plus 1 is 43. So 513 minus 110 is 413 divided by 43, that comes to 9.6 milliequivalent per liter. So after knowing this is the deficit or this is the amount you have to give, safe dosage to give will be 2 milliequivalents per liter. But for 1 liter, you calculate how much will have to be given, the volume you have to give. So 2 divided by 9.6 into 1000 is equal to 208 ml per hour of 3% saline. Okay, so this is the calculation. So you first calculate the amount required by subtracting the measured serum value from the infusate. Supposing you are using normal saline, it will be 154 is the milliequivalent of sodium in that. So 154 minus 110, and then the whole thing you have to do like that. So the calculation is done on the infusate that you are giving, whether it is 0.9% saline or 3% saline or 5% saline. You have to use that and then calculate and ultimately calculate it for 1 liter. Out of 1 liter, how much you have to give every hour. And a safe bet will always be to go for 100 ml per hour in any patient. Even if you do not know the calculation, for all practical purpose, when you are using 3% saline, it is safe to use 100 ml per hour so that you will not cause one important problem of transfusing 3% saline rapidly. What is that? Pontine myelinolysis or osmotic lysis. Okay, so that is the ultimate idea. So this is the formula, how much to give, you have to calculate weight into 1 liter of normal saline 153, whereas 3% saline 513. So change in serum sodium, infusate sodium minus serum sodium, total body water plus 1. So change in serum sodium, to estimate the 1 liter of infusate in serum and estimate the effect of 1 liter of any infusate containing sodium. If you are having potassium, then you have to take that also into account. What is indirect calorimetry? This is a new in thing in one particular segment of our management. Have any of you heard this terminology? Where it is being used? So indirect calorimetry measures the oxygen consumption and carbon dioxide production, just like your respiratory quotient, and provides an assessment of the energy expenditure. Now, what are its advantages? Indirect calorimetry is non-invasive, it is reliable and valuable tool in assessing the energy expenditure and fuel utilization, especially in patients in ICU management. Nowadays, we are giving a lot of importance to the caloric consumption and the ability of the muscles to perform so that patients can be weaned from ventilator as early as possible. So scientists from multiple disciplines have used it to measure energy expenditure, establish nutrient requirements, measure physical fitness, and evaluate macronutrient utilization during exercise and rest. So clinicians have used indirect calorimetry to optimize the nutritional support in metabolic disorders and to quantify the energy requirements in patients. So how does IC calculate energy expenditure? This is another part of that. So the volume of oxygen consumed and the volume of carbon dioxide produced are measured by indirect calorimetry over a period of time. The VO to VCO2 values are then used to calculate the resting energy expenditure using what is called modified Weir equation. So VO2, that is oxygen consumption, multiplied by 3.941 plus VCO2, that is the carbon dioxide production, multiplied by 1.11. The whole thing multiplied by 1440 will give the. So this is how this indirect calorimetry is done. Patient is covered with a hood to the entire face, and whatever he is breathing is calculated, and then the expired carbon dioxide is collected and measured. So who are the patients in whom IC is not feasible? Where you cannot do that. It is not feasible in patients due to specific subject requirements or device limitations or the need for expertise and resources. If you don't have all that, you cannot do. But nowadays, I heard in Andhra, Hyderabad, this is becoming a main thing in ICU management of patients, and they are utilizing this in a big way. What is shown here in this picture and what is the name of the line drawing? So you find a line drawing here, like the 3 leaves here. And you have got, are you able to see the small letters ES, QL, PP, and PM? These are all the abbreviations that are given. Can you identify what is that? Can you guess what could be QL, what is ES, what is PM, and what is PP? This sonoanatomy or sono picture. What could be QL anatomically?
Quadratus lumborum.
Quadratus lumborum. So along with that ES,
Erector spinae.
Erector
erector
spinae.
spinae. PM,
Psoas major.
psoas major. PP, transverse process. Very good.
Transverse
That's all.
process.
So all the 3 muscles around the transverse process. How does it look like when you draw them like this? It looks like what is called the shamrock sign. This is called the shamrock sign. The quadratus lumborum muscle forms one leaf at the apex and transverse process. Erector spinae muscle forms the posterior leaf. Psoas major forms the anterior leaf, and the transverse process forms the stem. So it looks like a muscle like this. Why it is called shamrock? Shamrock is a small plant with 3 round leaves on each stem. Do any of you know a leaf like that we use in prayers? Today is Pradosham. One of our own Tamil Nadu leaves have these 3 leaves arranged to a single stalk, which is mainly used for Archana for Shiva. Have you heard of Vilvam plant, Vilvam leaf? So this is how it looks. Okay, this is the shamrock plant, the leaf. The small plant with 3 round leaves, and that is why this name shamrock sign is given. Shamrock is a national symbol of Ireland. And how it is Quadratus lumborum block performed? This is another block which is now competing with the another paravertebral block. What is that block?
Erector spinae.
Erector spinae block and Quadratus lumborum block. Both are competing with each other. So Quadratus lumborum, you have 3 approaches: lateral, Quadratus lumborum block 1, which is lateral. Target is deep to the apnerosis of the transverse abdominis, but superficial to the fascia transversalis at the lateral margin of the quadratus muscle. Then there is the Quadratus lumborum block posterior approach, targets the posterior facial plane of Quadratus lumborum muscle deep to the middle layer of the lumbar fascia. And there is an anterior block or transmuscular block which covers the plane between the Quadratus lumborum and psoas major muscle. So this is how the patient is to be positioned for this block. So patient will be in lateral. This is the anterior superior iliac crest. The iliac crest, above which between the you just go in plane and go through external oblique, internal oblique, transversalis, and this is the Quadratus lumborum muscle. So you have to deposit the drug in the fascia between the transverse abdominis and the Quadratus lumborum. So this is the lateral approach, transducer position in a transverse orientation just above the iliac crest on the mid-axillary line. And insert the needle in plane and then go in the direction until the needle pierces the apnerosis of transverse abdominis muscle medial to the Quadratus lumborum. So we have to place the solution medial to the QL. And a volume of 0.2 to 0.3 ml per kg is described for this approach. And this is the next method, where posterior method, same position, same orientation, but it is in the mid-axillary line. Okay, so and slight posterior. Here slightly anterior, this is slightly posterior to the mid-axillary line. And needle is inserted in plane from anterior to posterior and toward the posterior surface of the Quadratus lumborum. Inject 2 to 3 ml of local anesthetic to confirm pooling along posterior approach and complete the block with the volume, same volume, and is this drug. One of the newer drugs. Not yet, I think, not come to our market yet, but because of the recent advances, I thought you may have to know this. What is this remimezolam? What is that? Yes. Okay, at all.
Benzodiazepine.
Shown here. The remimezolam, a benzo, it's something like midazolam. So remimezolam, okay, midazolam. So benzodiazepine group of drugs. How does it differ from midazolam? They're rapidly converted into inactive substance by tissue esterases, resulting in ultra short acting onset and offset. So it's a very, very short acting benzodiazepine. Okay. How is midazolam metabolized in the body, which you are using day in and day out? Midazolam occurs via hepatic routes.
Cytochrome P50.
To glucuronide conjugation and eliminated renally. Whereas remimezolam, which is a newer drug, is metabolized by the tissue esterases. Okay, like other, what are any other drug you know which are all metabolized by tissue esterases?
Atracurium, sir?
Bacterium is by blood esterases. Vivacurium. Okay? So remimazolam is marketed as a powder which must be reconstituted into liquid, whereas your midazolam is a liquid presentation. And the midazolam marketed as a clear colorless solution for IV use and also available in oral form, whereas remimazolam is not available for oral. What are the advantages of remimazolam?
Short duration of action.
Very completely
Rapid
reversed
onset.
by benzodiazepam antagonist flumazenil. Even if you give overdosage, you can easily reverse that. Minimal cardiac or respiratory depression effect. There is no cumulative effect at all. Even if you give it IV infusion for a long period of time, there is no accumulation. There is no burning sensation upon injecting remimazolam into patient's intravenous line, and non-anesthesia professional also have been permitted to administer this drug. What is chronic post-surgical pain? CPSP. This is from the latest BJ education supplement of British Journal of Anesthesia. It's a nice article on this. How do you define chronic post-surgical pain? Pain topics are always enigma for the students. I thought I will just add this. The definition of chronic pain, post-surgical pain is standardized in 2019 after the inclusion of new international classification of diseases and pain which develops or increases in intensity after a surgical procedure or a tissue injury is called chronic post-surgical pain. And pain should persist for more than 3 months after the triggering event. That is very, very important, because normally when the healing takes place, the pain will decrease. But if the pain persists for more than 3 months after the surgery or injury, then it is considered as chronic post-surgical pain. And localization either at the surgical area of injury or projected into an innervation area of the nerve in this area, or related to a dermatome or head zone of the surgery or injury, to deep somatic and visceral tissues also. So that is also considered as chronic post-surgical pain. The other causes may be the pre-existing condition, infection, malignancy should be excluded. So patient should not be suffering from already an existing painful condition. So this should be a new onset pain which is happening after the injury or the surgery. So chronic post-surgical pain can often show characteristics of neuropathic pain. It may be like a neuropathic pain. So what is the mechanism? The mechanism is peripheral and central sensitization. This is the mechanism for any pain rather, but for this is the sensitization occurring at both the site of injury as well as in the higher centers, spinal and supraspinal areas. There is an inflammatory and an immune response to axonal and tissue damage, including the release of neurotransmitters peripherally as well as in the spinal cord, leading to microglial activation, ectopic neuronal activity, and altered activity in the dorsal horn. There is also changes in the supraspinal processing, including brain network connectivity and changes in endogenous and descending pain modulation. So both stimuli from periphery and center, and alteration in the inhibitory factors. Normally we get the inhibitory fibers coming from the brain to suppress the pain. That also is affected. So what are the characteristics of CPSP? They are the consequence of central sensitization. Patient develops typical hyperalgesia, allodynia, dysesthesia, indicating nerve damage and sensitization. Hyperalgesia detected early after surgery, which might get prolonged due to chronic neuropathic pain like thing. And patients with neuropathic CPSP report more intense pain, more limitation of daily activity, and poor quality of life. The risk factors for CPSP are surgical risk factors, acute postoperative pain if it is not properly treated, that may continue as chronic post-surgical pain. That is the reason why we are nowadays thinking of multimodal analgesic technique to combat the acute postoperative pain. So if it is not treated at that stage, it may result in CPSP. And if the patient already has some preoperative chronic pain, definitely it may lead to CPSP. And psychological risk factors, psychosocial risk factors, and patient-related risk factors. The tolerance may be poor. So these are all this picture tells you it may be patient causes, anesthesia causes, surgery causes, and the nature of pain causes. These are the 4 things which are the risk factors for CPSP. Okay. So these are the newer things I thought I'll share with you. Right. Any questions? Any doubts? Much change?